High bleeding risk patients is an heterogeneous group of patients in whom the predicted risk of bleeding events up to 1 year after having received an intervention, a coronary intervention, is much higher than average. Recently, the Academic Research Consortium has provided a clear cutoff. If the major bleeding risk is at least 4% at 1 year, this is the point in which that specific patient population should be labeled as HBR, high bleeding risk. And the reason why we need to identify them upfront is because, of course, we may want to modulate treatment duration and intensity so that the bleeding risk will also be lower. The rationale for setting up and conducting the MASTER DAPT study comes from the fact that until now we didn't have any randomized evidence informing us on the optimal duration of dual antiplatelet therapy, specifically in patients at high bleeding risk. Actually, we already had 2 one-month DAPT studies in the past. However, this was not addressing specifically high bleeding risk patients in whom the price to pay for bleeding complication is much higher than average, of course, or they were selecting patients at relatively low ischemic risk. We screened patients undergoing PCI who were at high bleeding risk, and then we treated them with an implantation of one or more of Ultimaster stent. If they were completely stable at 1 month after PCI, meaning without any recurrent ischemic events, or in patients in whom no further revascularization was planned, then patients were randomly allocated to immediately stop DAPT and followed by a single antiplatelet therapy for up to 11 months or 5 months if there was a clinical indication to oral anticoagulation, or to continue DAPT for at least 2 or 5 months in patients with or without indication to oral anticoagulation respectively, followed by single antiplatelet therapy. The MASTER DAPT had pre-specified 3 ranked primary endpoints, being NACE, the composite of death, MI, stroke, and major bleeding, then MACE, major adverse cardiac and cellular events, as the composite of death, MI, stroke, and finally major or clinically relevant non-major bleeding. With respect to those, we found a non-inferiority for NACE. Then we tested the non-inferiority for MACE, and that was also met. And finally, we were able to prove the superiority with respect to the third co-primary endpoint. So in summary, we saw that abbreviating the duration of DBT down to 1 month after PCI and after Ultimaster stent implantation was associated to similar risks with respect to NACE and MACE, but much lower bleeding risk. The results of the MASTER DAPT study are very clear and clear-cut. I think 1 month DPT now, it's getting and becoming the new standard of care in patients that are undergoing PCI in whom an high bleeding risk feature is present. We have shown that there is no penalty to pay with respect to ischemic events by reducing the DPT duration down to 1 month, and in fact there is only to gain with respect to the bleeding risk.